So this is just a quick overview of what I've picked up about Ebola fever from just CDC, WHO, and JAMA publications over the course of a day or two of intense web browsing. I put this together on October 15th. The Ebola virus is a member of the family Filoviridae, so-called because it has this filamentous structure to the virus itself. Within that family, there are two genuses. There's the Ebola virus and the Marburg virus. Both are negative-sense single-stranded RNA viruses. They are non-segmented, which means that unlike the HIV virus, they don't utilize a reverse transcriptase. They just use a standard RNA transcriptase. So theoretically, HIV drugs would not be useful against this particular virus. They do, however, resemble Rhabdoviridae and Paramyxoviridae families, the former of which causes the rabies virus. Within the Filoviridae family, the Ebola virus contains 5 species. There's the Zaire Ebola virus, which is the most lethal and the most common. There's the Sudan Ebola virus, which is the next most lethal and the next most common. These are all named basically by the region in which they are found. The Thai forest virus is has never actually been found in Africa. It's only been seen in Thailand. And the Reston virus is interesting because it actually doesn't cause disease in humans, only primates, even though humans have been exposed to it. Also within this family, there's the genus Marburg virus. The Marburg hemorrhagic fever actually predates Ebola hemorrhagic fever by about 10 years, and a lot of our information on Ebola virus is actually just like extrapolated knowledge we have from the Marburg virus, so I thought it deserved a couple of slides. Marburg hemorrhagic fever was first seen in 1967 across Europe when scientists handling the organs of African green monkeys became ill. It was a similar presentation to Ebola virus in that it was this sort of non-specific flu-like illness which ended in multi-organ failure and hemorrhage and unexplained bruising. 7 deaths were reported during that outbreak, and then since then there's been sporadic outbreaks across Africa, much like there has been with Ebola. We do know that this particular virus is carried by African fruit bats, and a lot of times African cavers or African miners are the first affected by the outbreaks. So it's thought that Ebola virus may also be carried by African fruit bats. The Ebola virus was first discovered 10 years later in 1976 near the Ebola River, which was then in Zaire, which is now the Democratic Republic of Congo, and in southern Sudan. So those are the Zaire variant and the Sudan variant of the Ebola virus. At the time, both outbreaks were highly lethal. The Zairean cases had a 90% mortality. The Sudanese had a 50% mortality. The Ebola virus is zoonotic, meaning that it does utilize an animal host at some point during its life cycle. It's thought to be bats again because the Marburg virus uses bats, but we're not actually sure what animals are carriers of this virus. It is thought that only primates and humans actually will become ill by the virus, as far as the CDC knows at this point. The exact method of transmission is a little unclear. However, in person-to-person transmission, which is the means of infections during outbreaks, it has been firmly suggested that close personal contact between infected individuals or their bodily fluids and another person is the main culprit. So close personal contact basically means bodily fluids of an infected and symptomatic individual getting into the mucous membranes or into an open wound of a non-infected human. So according to the CDC, this is not an airborne disease. It would have to get onto your mucous membranes or into an open wound, and I'll go into that further in the transmission section. It is thought that in Africa there's this cultural tradition of washing the dead before they are buried, and it's thought that that has been a big culprit in the transmission during these outbreaks. So this is just an interesting poster I found from the CDC. I thought it was kind of funny. The bottom right of this poster states that Ebola poses no significant risk to the United States. They do quite vehemently point out that you can't get Ebola through air, so it's not airborne, it's not waterborne, it's not foodborne. And again, they're very strongly suggesting that only through direct contact with bodily fluids of a sick person, meaning blood, saliva, etc., and then transferring that material onto one of your own mucous membranes, so mouth, nose, eyes, or into an open wound. That, according to the CDC, is the only way you can get Ebola. It is thought to be highly virulent, which means that the actual number of viral particles you need to get into your system is very low to cause an infection. So a little more on transmission, close contact, which I mentioned. When we've had outbreaks, historically, we've just minimized close contact using gloves, using masks, using quarantine precautions, and that has basically been how we've dealt with outbreaks historically. There really hasn't been much along the lines of novel treatments until now. There are some now, which I'll talk about later. And again, the CDC strongly denies that there is an airborne mode of transmission for this virus. That's just what I was saying about transmission. So here's the current gowning protocol for hospital workers and healthcare workers dealing with Ebola. You can see there's some gowning, some face masks, a face shield, and gloves. There was some backlash from some nurses in Texas about the exposed necks on phase number 3 under goggles or face shield, stating that the neck skin is actually exposed even with this gowning. But as I mentioned, the CDC strongly denies that the virus can make its way in through closed skin, and that the virus only makes its way into the body through mucous membranes or open wounds. It's also been, questioned, so how is it that multiple nurses working in the same hospital with the same gowning precautions are picking up this disease? How are doctors getting it if they're all using these precautions? One explanation was that they were not gowning properly. Another one is that they were taking off their gloves improperly and spreading from the outside of one glove to the inside of another glove onto their hand, and then somehow managing to touch their eye or their mouth before washing their hands. That's the explanation as it stands. It is a little curious, and I think maybe some more research into transmission of this disease is pertinent. However, the CDC strongly denies that it can make its way in through closed skin or airborne mode of transmission. So, signs and symptoms include a fever greater than 101.5 Fahrenheit, and that's where Nurse 2 actually, where the trouble started with her was she actually had a low-grade temperature before traveling, and I believe contacted the CDC and reported that she had a low-grade fever and was cleared to travel because it was below this 101.5 degrees Fahrenheit guideline. Overall, the signs and symptoms are just a general flu-like illness, very vague, headaches, muscle pains, weakness, diarrhea, vomiting, abdominal pain. There's some hemorrhage, bleeding, or bruising, but that's normally very late stage. That's not early in the disease. That's towards the end. And the incubation period of this disease is approximately 10 days. It can be anywhere from 2 to 21 days, but basically after a person is exposed, around 10 days is when they will start to show symptoms. So when nurse number 2 got on the plane about 2 weeks ago, I guess it was, from Cincinnati back to Texas, and there was all this concern about did she infect anyone, did she contaminate anyone? They would have started to show signs by now, signs of the disease, more than likely, because it has been more than 10 days, and I don't believe there have been any signs. So As far as pathogenesis of this disease goes, Ebola virus is thought to enter again through mucous membranes, breaks in the skin, or parenterally, which means basically needle sticks. The pathogen infects many cell types and eventually causes multi-organ failure, but it seems to have an affinity for antigen-presenting cells, including macrophages, dendritic cells, and monocytes. And because we have this difficulty performing clinical studies, we've basically just been doing either mouse studies, primate studies, or extrapolating data from similar viruses. Basically, when the virus pops up in an epidemic, we haven't been studying the subjects, the patients. We've just been quarantining them, treating them, and trying to get rid of the disease as fast as we could. So once the first-line macrophages, dendritic cells, antigen-presenting cells are infected, the filoviruses replicate and spread to the extracellular fluid, and then start infecting different cell types, different organ types, and like I said, eventually cause multi-organ failure. The next step would just be rapid systemic spread and a suppression of the body's immune responses. There is a SIRS syndrome, or a systemic inflammatory response, which is caused by the release of cytokines and chemokines from the infected antigen-presenting cells. I'm just going to refer to them as dendritic cells for now, because those are the most commonly infected cell types. So the release of inflammatory cytokines like tumor necrosis factor alpha, interleukins 1 and 6, macrophage chemotactic protein, and nitric oxide causes hemostatic instability, causes fever, causes malaise. Again, this is all due to the host response to the infection rather than the actual virus doing this itself. It's caused by the dendritic cell's response to being infected. Also, the virus can cause a series of coagulation defects similar to disseminated intravascular coagulation. Basically, it does this directly and indirectly. Directly by causing the infected dendritic cells and macrophages to release tissue factor, which is the main protein involved in the extrinsic coagulation pathway. So basically, you have clotting within blood vessels, which causes a consumptive coagulopathy and a consumptive thrombocytopenia and hemorrhaging. The virus also has a way of impairing the adaptive immunity of its host. It first of all will impair the innate immunity by directly affecting cells involved in innate immunity, such as dendritic cells. It then impairs the adaptive immunity by knocking out signals from the innate immunity, and also by causing bystander apoptosis of lymphocytes and subsequent lymphocytopenia. However, it's important to note that patients will recover their lymphocyte count and their white blood cell count in about 10 to 20 days if they're managed properly and if they're able to survive long enough to do so. So discovering ways to accelerate and strengthen such responses may prove to be a fruitful area of research. This is another poster by the CDC just on the symptoms of Ebola. Remember, it normally pops up about 10 days after exposure, and it's sort of a vague flu-like syndrome. So, like I said, the hemorrhaging and the bruising associated with Ebola hemorrhagic fever are actually pretty late stage, so we're not even calling Ebola hemorrhagic fever by that name anymore. We're just calling it Ebola virus disease now, because hemorrhaging is a late stage and slightly less common manifestation of the virus. The incubation period, like I said, is about 10 days, and according to the CDC, there is no evidence that asymptomatic persons who are still in that 10-day period can actually be infectious. So I'm going to use Nurse 2 again as an example, but when she was on the plane and she was only vaguely symptomatic, she had this low-grade fever, according to the CDC, she really wasn't shedding the virus to any notable extent at that point. So really, until a patient is acutely ill, they're not really going to be spreading the disease at all. So that's sort of good news in its virulence. So again, it starts as a nonspecific flu-like illness. It's an abrupt onset, headache, general malaise, fever, chills, and it can also be associated with a pharyngitis or sore throat with a lump or a ball in the throat. There's this rash, which is a hemorrhagic rash, and there's also desquamation, which basically means the skin will start to shed. Even after a patient recovers, they will oftentimes have lost a good amount of their skin or hair. There's some GI manifestations, diarrhea, nausea, etc. Hemorrhaging we've talked about. That's again a consumptive coagulopathy. There's conjunctival injection, which is just really red eyes, and same thing with the soft palate can oftentimes turn very red, and that's just due to the bleeding defect again. So prognosis, right around 10 days, patients will either get a lot better or a lot worse. So that's sort of the tipping point there. If a patient is able to survive long enough to mount a decent immune response, they'll hold antibodies for about 10 years to this disease after they recover. So right around 6 to 11 days, patients can start to improve, and they'll form these antigen-antibody complexes, which will cause a type 3 autoimmune response, which will cause some acute arthralgias and other symptoms, sort of similar to an immune serum sickness, and that's just part of the late-stage sequelae of recovery. The more severe your symptoms are, the worse the prognosis, obviously, and death can often occur between days 6 and 16. In the lab, you might find leukopenia, more specifically lymphocytopenia, which is often followed by an elevated neutrophil count, so it's sort of like a compensatory granulocytosis with a primary lymphocytopenia. And those will all be immature forms as the body is trying to form new neutrophils. Again, you will have a increased granulocyte count, and eventually the lymphocytes will rebound if patients are supported well enough and are able to basically stay alive long enough to do so. There's that consumptive thrombocytopenia, which is what causes the bleeding defects. There's a transaminitis. The liver is hit pretty hard by this disease, and I believe that's because a lot of dendritic cells may be resting in the liver. Coagulation abnormalities similar to disseminated intravascular coagulation, which I've explained, which causes an elevated prothrombin time. There's some renal abnormalities. So basically to manage these patients, we've just been using supportive care and quarantine precautions to date. Really the only FDA approved or the primary method of treatment is just supportive care. Keep the patient, keep their blood pressure under control, keep the coagulopathy under control, just treat the symptoms long enough for the body to mount an appropriate immune response. And then after patients do recover, by the way, this current outbreak has about a 50% mortality, which is down from the 90% mortality of the first outbreak. When they do recover, they will hold antibodies for about 10 years, and they can maintain, they can remain infectious for about 3 months or more after recovery. Their bodily fluids may maintain their virulence. One case, actually in the original Marburg outbreak, showed sexual transmission a few months after the patient recovered. So there's talk of transmission through semen after recovery. After convalescence, it's basically a slow, painful process back to health. There is sloughing of the skin and hair loss commonly observed. It takes a toll on a person, but full recovery is possible. So there's a number of good treatments in the pipeline now that I think are very hopeful. ZMapp is the one that people have been talking about. It's the experimental treatment that was used in Africa on those 2 healthcare workers. It's basically a cocktail of 3 monoclonal monoclonal antibodies to the glycoproteins on the outside of the virus. It's got about a 50% success rate, and I think it has to do with how late in the disease progression the patients were when they were administered the ZMapp. There's also some other novel treatments. The World Health Organization has recommended the use of whole blood or serum from recovered Ebola virus disease survivors for currently affected patients, and that's in the hope of transferring that the antibodies that they hold. There's a novel antiviral agent, brincidofovir, which is originally meant to treat cytomegalovirus, but it's showing some promise against the Ebola virus. And as far as post-exposure prophylaxis, meaning after a patient is exposed, but before they start to show symptoms, there's also a number of treatment options there. First and foremost, the CDC should be contacted. There is a live virus vaccine using the VSV virus, the vesicular stomatitis virus, which just started clinical trials 2 weeks ago, which shows some promise. That's the vaccine that everybody's talking about. It may be marketable in 2015, but it was very quickly put together and is being tested on humans already. There's also this small interfering RNA therapy, small molecule therapeutics, which I found very interesting. Basically, they just get in the way of the virus's normal reproductive cycle. You're just bombarding with similar small molecules which can inhibit the transcriptase and other viral stuff that happens. So anyway, that's had up to 100% survival, so 100% efficacy if given in 60 minutes after the virus challenge, so very good news. There's also this new drug, BCX4430, which is a viral RNA polymerase inhibitor, directly inhibiting that RNA polymerase. That's shown some promise when given as late as 48 hours after infection. Monoclonal antibodies, like we talked about, ZMapp, are showing some promise. And interferon alpha treatment, which has been used in some other diseases, is kind of iffy as to its efficacy. The current outbreak, just a couple words on that, is the biggest in history. It's the first time it's made it to America, to the Americas. As of the beginning of October, there was 3,000 deaths from the disease. I think currently we're closer to 5,000 now at the end of October. The mortality rate is approximately 50%, which I mentioned earlier. It's down from 90% at the original outbreak. This is the Zaire variant of the Ebola virus, and the most affected countries so far are Sierra Leone, Guinea, Liberia, Nigeria, all the far western, northwestern African countries. So there's been a couple of computer simulations and some speculation that has been a little bit grim. One simulation suggested that there would be 20 new cases expected monthly in the U.S., one suggested 10,000 new cases worldwide per week. These don't really account for human interventions and our novel therapeutics. They're not actually worst case scenarios, but they are sort of bleak in their outlook as far as human intervention goes. So with that said, I'm just going to leave you guys with some pictures of puppies, just some adorable puppy pictures. I know that was kind of a grim ending for that presentation, but have no fear. Have no fear. Carry on. We'll be fine.